MYX to fix aphakia, a novel technique for sclera-fixated intraocular lens implantation. The authors have no financial interests. So cataract is the leading cause of blindness in the developing world. The ideal situation after any cataract surgery, whether it be a phacoemulsification or a small incision cataract surgery, is the implantation of a foldable intraocular lens or a rigid intraocular lens into the bag. What we don't want is aphakia. So this could be a result of an intraoperative complication, a congenital anomaly of the lens, or it also could be traumatic in origin. So various options have been described in literature, from the ACIOL to the retrofixated iris claw IOL to the most popular ones being the sclera-fixated IOLs. The sclera-fixated IOLs are stationed posterior to the iris plane and therefore avoid the corneal decompensation that is seen with the ACIOLs. Various surgical approaches have been described for them, from the sutured to the glued to the gabors to the Yamane to the X-knit technique and many more. So we describe a novel technique known as the MYX technique, which is a modified adaptation of the Yamane and X-knit techniques for sclera-fixated intraocular lens implantation, where the externalized haptic is cauterized to form a flange transconjunctivally, thereby avoiding the scleral pocket tucking like the Yamane technique, and the handshaking of the proline haptic of a 3-piece PMMA IOL into the lumen of a 26 DS needle is done externally like the X-knit technique. Therefore, M stands for modified adaptation, Y for the Yamane technique, and X for the X-knit technique. So here's a case of an anterior subluxated lens where a phonic space conjunctival flap was made. This was followed by the making of a superior sclero-corneal tunnel. The incision was made with the 15 number blade, and using a crescent knife, the tunnel was created. The third part of the triplanar tunnel was entered with using a 2.8 mm keratome knife. OVD was injected into the anterior chamber, and this third part of the tunnel was enlarged. The dislocated lens nucleus was removed using via VECTIS. The limbus was marked at 0 and 180 degrees using a corneal suture marker. Since the pupil was small, we had placed 2 iris hooks to have better visibility and easy maneuverability. Automated anterior vitrectomy done to remove any vitreous. So marks 1, 2 and 3 and 4 were put, where mark 1 was 2 mm nasal to the 0 degree limbus, mark 2 was 2 mm temporal to the 180 degree limbus, mark 3 was 2 mm inferior to mark 1, and mark 4 was 2 mm above the mark 2. This was a 3-piece PMMA IOL from Orolab. An angle sclerotomy was done via mark 3 using a 26 gauge needle. You can see the needle present behind the iris plane. The needle was then directed out of the tunnel over the iris plane. McPherson forceps was used to help in this maneuver and to prevent damage to the iris. The leading haptic of proline of the IOL was introduced into the needle lumen. Then the IOL was directed into the anterior chamber, and in the same time the needle was brought out via the sclerotomy site. The end of this proline haptic was then cauterized with bovie cautery to produce a flange which was greater than the size of the sclerotomy. OVD was injected into the anterior chamber. You can also use an AC maintainer or a pars plana infusion, which will make the surgery a little bit easier. In the same way, a needle sclerotomy using a 26 gauge needle was done via Mark IV. The needle was directed into the anterior chamber behind the iris plane, and then this needle was brought out just near the section. The problem with the 26 gauge needle is that it's of a smaller length in what is required. So a better position would be to use a longer length needle. So the trailing haptic was introduced into the needle lumen. And the needle was brought out via the sclerotomy site. The haptic was exteriorized and its end was again cauterized using bovie cautery to produce a flange. These two flanges were then buried subconjunctivally. You can note that the eyeball was very stable and well centered. The iris hooks were removed. The sclero-corneal tunnel was sutured with 10-0 nylon. The side ports were hydrated. And the conjunctiva was also sutured using 8-0 Vicryl. You can note that the IOL is very well placed. So, the MYX technique is an easy, fast and a reproducible technique which uses the advantage of both the Yamane and the X-knit techniques. Thank you so much.